Hello, a warm welcome to this session on hidden symptoms. My name is Rowan Wathes. I'm the Associate Director of Policy and Health Strategy at Parkinson's UK, and I'm delighted to be chairing this session. So, what are hidden symptoms? Well, these are those non-motor symptoms that you can't see, the ones that you might not even be sure whether they're Parkinson's or not, the ones that you don't necessarily get asked about in your clinic appointments, and potentially some of the symptoms that people might find more embarrassing. We have three wonderful speakers talking to us first, and so they're each going to give a short talk, and then we'll have plenty of time at the end of the session for questions and comments. So if you're in the online audience, please do use the chat function to add your questions and comments. So I will start by introducing our speakers. The first speaker is going to be Claire Stevens. Claire cares for and supports for her husband, who was diagnosed with Lewy body dementia at the age of 65, following a Parkinson's diagnosis the year before. Both Claire and her husband are very involved with the Edinburgh Parkinson's UK branch. And Claire has had a wonderful career herself. She's held paid and voluntary roles in Scotland's third sector for over 40 years and is currently a trustee of the Neurological Alliance of Scotland. And in 2021, the Faculty of Public Health elected her as an honorary member for services to public health. Our second speaker is going to be Emma Edwards. Emma has been a qualified mental health nurse for 28 years. She's often known as the Beyoncé of Parkinson's nurses and has spent the last 14 years working as a specialist nurse in the community in southwest England. She has a special interest in suicide prevention, and she also does a regular podcast with people living with Parkinson's about young onset Parkinson's. And she sits on the Royal College of Nursing's Neuroscience Nursing Forum. And then our final speaker is Dr. Robin Fackrell. Robin is a consultant physician and specialist in Parkinson's and related disorders at the Royal United Hospital in Bath, where he runs the multidisciplinary movement disorder service. If Emma is the Beyoncé of nurses, then Robin is the Tom Hanks of Parkinson's doctors. He's an honorary senior lecturer at the University of Bristol. He's a fellow of the Royal College of Physicians, and he has a master in healthcare ethics and law. His particular interests are non-motor symptoms of Parkinson's and palliative care. So without further ado, we're going to start with our first speaker, and that's Claire. Over to you, Claire.
Thank you, Rowan, and good afternoon, everyone. I'm just so pleased to be here. As Rowan said, my husband has dementia with Lewy bodies alongside his Parkinson's diagnosis. And so for that means I wear all sorts of hats. I'm his closest person, I'm his carer, I'm his diary secretary, financial manager, digital troubleshooter, interpreter, and advocate. So today I'm talking wearing my various hats. I'm not attempting to wear his hat or tell his story. This is my story from my perspective. So a bit about us. We're both in our mid-60s. I retired earlier this year in order to have a bit more bandwidth, as I say, for Kenny, my husband. We live in Edinburgh in Scotland, and we don't have any family locally at all. And I suppose for me, beyond the day-to-day routine of trying to live our best lives with and despite Kenny's dementia with Lewy bodies and Parkinson's, I've been finding it really helpful to channel some of our experience and learning in a direction that might possibly help other people. So that's meant reaching out to and linking up to health professionals, researchers and academics, civil servants and various charities, mainly in Scotland, to help spread the word that Parkinson's and dementia can go hand in hand, and to make the case for better diagnosis, research and post-diagnostic support. So a bit about our journey, and our Parkinson's and Lewy body journey with hindsight began on Boxing Day 2018, literally with a journey along the M8, driving home after spending Christmas with my husband's sister in Glasgow. We were driving home to Edinburgh, and along the M8, in the dark, in the quiet, and with no alcohol having been consumed, my husband twice tried to get out of the car. And this was frightening for me, terrifying, and frightening for him. And we didn't know what was going on. It was almost not spoken about afterwards. But in hindsight, that was the first sign that something cognitively was beginning to go a bit haywire for my husband. Anyway, by the start of the pandemic, my husband was displaying more, I suppose, of the classic signs of Parkinson's, really. A noted change in gait and loss of weight, bowel and bladder problems, and so on. But also these cognitive problems. It was as if the world was no longer quite making sense for Kenny. So simple tasks like hanging the washing out on the line just were becoming insurmountably complicated for him. And it was when I thrashed Kenny at a game of Scrabble that I knew something was seriously wrong. That had never ever happened in our 30-odd years of being married. So Kenny was diagnosed with Parkinson's in October 2021, and we immediately got involved with Parkinson's charity, and it's been an absolute godsend. The Edinburgh branch, and indeed Parkinson's Scotland and Parkinson's UK have just been absolutely brilliant. But I suppose the Parkinson's diagnosis didn't really seem to fully explain Kenny's increasing cognitive challenges. And it was as if the issues were sidelined. If we tried to talk to the Parkinson's consultant or the Parkinson's nurse about it, we keep getting told, oh, it'd just be Parkinson's related anxiety. We even used the word dementia and say, could this be dementia? Oh no, it's probably just Parkinson's related anxiety. And actually within the Edinburgh Parkinson's community, it felt a bit as if the word dementia was the elephant in the room. Nobody really wanted to mention that or talk about it. So it was a bit isolating because we were both really quite worried. So eventually, by going back to my husband's GP and pushing, there was a diagnosis of dementia with Lewy bodies. And so what happens with that is we were directed then into the path of old age psychiatry and mental health professionals, as well as neurology. And we've kind of juggled our way between these different parts of the NHS ever since. So on the plus side, that meant being allocated initially a really wonderful community psychiatric nurse for nearly 18 months. And also my husband is now on medication for life to try and slow the progress of the dementia. But I suppose despite that, rather than feeling that Kenny's healthcare is always part of a joined up and compassionate and kind system, it's sometimes felt as though we've fallen between the various stools labelled neurology, psychiatry, old age medicine. It's quite horrible finding yourself suddenly in old age medicine at the age of 65 and mental health. And I think also dementia often seems to be seen as a social care issue and not a health issue. So I was asked if I could talk a bit about, how we've overcome the challenges. And I suppose one of the key things I want to say really is that if you know in your bones that something isn't right, keep asking questions and seek out different opinions. You know yourself best, you know your loved one best, the person you're closest to. Be persistent, get a second opinion. Don't be afraid to ask, to see, or move to another consultant. And we got help from Parkinson's Scotland to do this. And Kenny is now in the care of a consultant who not only specialises in old age medicine and Parkinson's, but he's absolutely passionate about improving the care pathway and support for people who have Lewy body dementia or Parkinson's dementia. And I think also sort of be prepared for mixed levels of understanding and experience of Parkinson's related dementias amongst health and care professionals, and be confident about your own expertise and sharing it. I hope I managed to stay polite and to think myself into people's shoes, whether they're neurologists, GPs, OTs, social workers, nurses, and link workers, and so on. They're invariably trying to do their job to the very best, and diagnosis of any kind of dementia associated with Parkinson's, it's not straightforward. It's complicated to manage medically. The resources and support available for dementia aren't necessarily appropriate for what you need. So I've also learned that sometimes I have to suck it up and be realistic. And I've learned to pick my battles. So work out what's most important to you, and also identify who your most reliable allies and sources of professional support are. So currently for Kenny and me, that's our new GP, his new consultant, his wonderful private neurophysiotherapist who's working wonders with him, and his team of carers. But equally important for us, we lean heavily on the voluntary and charity sector. So that's Parkinson's UK, but also rare dementia support at the University College London, who've got wonderful support there, and local resources. So we live almost next door to a wonderful project in Edinburgh called Bridgend Farmhouse, where people understand us, understand my husband, and are really kind and understanding. Moving towards my final remarks, really, I wanted to say something about a group that Parkinson's UK has just set up that I'm really excited about. It's a working group in Scotland that has been set up to look at how we might actually improve things for people who've got a dementia as part of their Parkinson's diagnosis. So we're a group comprising both people with lived experience of Parkinson's-related dementia and also families, friends and carers of people in that situation. We're from all over Scotland. We had our first meeting last month. We've been facilitated by Parkinson UK's Area Development Manager. And we want to use our lived experience of caring for someone with Parkinson's and a dementia to raise awareness about the need for, I suppose, better and earlier diagnosis, treatment, research and support for everyone who's affected. So it's very early days, but we're starting to identify some areas where we think there's room for improvements, and just a couple of reflections taken from ideas discussed at that very first meeting. Some people felt quite strongly we shouldn't call dementia with Lewy bodies and Parkinson's dementia and other dementias of this kind rare dementias. They're not rare. I mean, everybody talks about dementia and they think you're talking about Alzheimer's, but these other dementias, they're not rare. They are less common and they're certainly more overlooked. And they're not just a disease of old age. People can acquire them much younger. And I think Robin might say something about this. People with Parkinson's are at a higher risk than some. And so with Parkinson's, the fastest growing neurological condition worldwide, related dementias are growing too and need to be better understood and supported. And I suppose hand in hand with that, and I suppose my most important remark, reflection really, is that we just need to create more interest, compassion and understanding about dementia and Parkinson's across the health and social care workforce, including neurologists, Parkinson's nurses, but also primary care, residential and nursing care, daycare, respite care, and also within the charity sector. And I think amongst ourselves, within the Parkinson's community and within all our communities. And we shouldn't be afraid to talk about dementia and Parkinson's. We shouldn't stigmatise it. We can bring the elephant out of its corner and further into the room if we do it with kindness and sensitivity. It may be something that seems scary, something we'd rather not think about, but dementia will sadly be part of some people's journey through Parkinson's. So let's do what we can to make that journey as well supported as we can. My husband isn't here today, but he has this wonderful phrase. He says to me, Claire, the doing needs done. So on that end, I will end. The doing does need done. Thank you, everybody, for listening.
Oh, thank you so much, Claire, to you for sharing that story, to Kenny for being happy for it to be shared with everyone, and for those really practical tips and inspiring words at the end. Thank you. So we're on now to Emma, who's going to continue with our speakers. Thank you, Emma.
Hi there. Thank you so much, Parkinson's UK, for inviting me along today. It's an absolute honour, and it's so lovely to see everybody, people that I followed online, people that I Zoom in with to see them in the flesh. Fantastic. So, yeah, as Rowan said, I'm a Parkinson's specialist nurse, but I'm also unusually a mental health nurse, a psychiatric nurse, and I have been for a very long time. And those skills from my mental health nursing days have been absolutely invaluable being a Parkinson's nurse. So I sit here really with two hats on, one being a Parkinson's nurse and another one being working with Spotlight YOPD, which is a fantastic charity that supports people with young onset Parkinson's. But first of all, I'm going to speak about how I assess mental health issues in Parkinson's. So I genuinely want to know about people's mental health, and when I do my assessment, I incorporate those questions and sort of thread them through my assessment. And I do find it takes no longer than doing just a straightforward Parkinson's assessment. And I teach all over the country actually about encouraging clinicians to ask about mental health issues in Parkinson's. And we know it's there, don't we? You know, depression, anxiety, cognitive problems, the rate of those is quite high in Parkinson's. But mental health, when we talk about that, it's more than an absence of mental illness. It's complex. It's different for everyone. And we know that mental health and physical health are, you know, intrinsically linked. And I think with Parkinson's it's really difficult to hide it. I'm sure, you know, many of you will know when you get anxious or stressed, your tremor may increase or your dyskinesia might increase. So it's really, really sort of helpful for us as clinicians to find out how your mental health is affecting your Parkinson's. And I think as well, listening to Rochelle Flanagan this morning, I think it is different how Parkinson's and mental health affects women and men. So I think that's important to point out. Something that I find that is essential, and I think as clinicians we're trained to do this on day one, is to build that rapport with the people that we work with. And I think that's massively important in appointment settings, because I think we're going to be asking some you know, perhaps some very personal questions. And I find that if that rapport is there, then people will answer more authentically, but feel safe to do that as well. And so I ask quite direct questions. I find it's important to be clear when I'm assessing for mental health. So I may inquire about depression, your mood, hallucinations. If you are experiencing suicidal ideation, I will kind of go there as well and find out a little bit more if it's appropriate. I think something that I also feel is really important is also to build a rapport with the care partner, the wife, the husband, the daughter, whoever comes along, whoever is their supporter. So it's helpful to know from their point of view how the person with Parkinson's is coping, but I also want to know if they're coping as well. So it's really, really helpful to get that information, get that 360 picture of what is going on. But I find what is really important is to know what to do with those answers. So I very much kind of come at it from a medical point of view and a non-medical point of view. So it may well be that if somebody is very depressed or experiencing hallucinations, it may be that we look at changing their medications, tweaking them, adding something in. But it may be that we need a referral to the mental health services. I work very closely with our local social prescribing team, who are absolutely fantastic. So, you know, for example, I can tell you about the local Parkinson's groups in the area, but if your interest really is fishing, you might not be interested in going along to one of my groups. So it's about finding out what is out there in the community that might you know, be of interest for you. I also run a monthly online carers group, which I run alongside one of our caring organisations, and everybody that comes along to that also are offered a formal carers assessment, which you are entitled to by law. So with my sort of Spotlight YOPD hat on a little bit, what I do find in terms of YOPD and mental health is that it's that the stresses are slightly different, perhaps from somebody who's retired. So we know getting the diagnosis of Parkinson's can be devastating, regardless of what age you are. But when you are younger, there's different challenges. You may have a family, you may still be working. So those worries about the future, about finances, about feeling a burden to others, relationships, work, it's incredibly complex and an incredibly stressful time. What we hear at Spotlight YOPD is sometimes that people have been signposted to the local Parkinson's groups, and perhaps there's if they can go along at all, because it's usually in the daytime when they're working, but when they go there, perhaps there is older people there, and perhaps the younger people not so much there. So they start to feel very isolated and lonely. And we know that mental ill health thrives in isolation and secrecy and worry. So it's really, really important for us as clinicians to understand that people with younger onset Parkinson's have a different set of needs. So I think it's important for all of us in terms of our mental health to find our tribe. I think social isolation is a big no-no, and to avoid it at all costs. I think it's important to be aware that Parkinson's affects your mental health, but also, research sort of suggests that if you've had a history of depression and anxiety when you were younger, that Parkinson's, I think it's twice as more likely to develop. There's some fantastic research projects going on in terms of mental health. And so I really sort of encourage you, and I've loved today and the sort of that call out to be empowered by research as well. And so don't dismiss mental health research. Yeah, so that's me. Rowan, is that okay? Was I to time? I think I just ran over maybe a little bit.
No, that was absolutely perfect. Thank you so much, Emma.
Okay.
That's given us a real insight into how you manage your clinics, and perhaps given some people some tips about how to raise things with their specialists. So thank you so much. So we'll go on now to our final speaker, Robin, who's going to give the sort of doctor perspective and talk about some of those other non-motor symptoms as well. So over to you, Robin.
Thank you very much. Can you hear me okay?
We can, yes.
Perfect. So I'm Robin Fackrell. I'm a consultant physician and I'm a Parkinson's specialist down in sunny Bath. Well, it is sunny at the moment, but it's been very wet for now. And it's such a privilege to be talking to you today. And I'm really grateful for the opportunity to do so. I'm a passionate advocate for Parkinson's disease and particularly non-motor symptoms and recognizing them. And I think we've really got to change the emphasis of the way that we as clinicians manage consultations and manage our patients, because for far too long, the doctor knows best, and a very paternalistic viewpoint has pervaded the way that Parkinson's is managed. And I think it's time that really changed. And really, the main focus of any consultation needs to be quality of life. And it needs to be your quality of life. And oftentimes, non-motor symptoms can really get in the way of you enjoying a good quality of life. Now, Parkinson's disease is a complex thing. And oftentimes, given the pressure of time in a consultation, clinicians will often just look at what they can see. So they'll look at the tremor, they'll look at the stiffness, they'll look at the gait, but they'll very rarely tap into the hidden symptoms, the wide variety of non-motor symptoms, which often can cause quality of life to be at their lowest. And I think that's where advocating for patients and empowering patients to say, well, wait a minute, that's fine, but I'm really worried about this. So what I would suggest to people is when you're preparing for consultations, write those lists and make sure that you cover the issues that are most dear to you, the things that you're worried about. And if you think that something's wrong and you've got a symptom that you don't know what it is, check, because it could well be part of the Parkinson's syndrome. Now, this is a this was drawn in 1817, this picture, and we see patients with Parkinson's disease with tremor, rigidity, and all of those things. But what we can't see is things like anxiety. We can't see the depression that Emma was talking about. All those, and Parkinson's runs the whole gamut of neuropsychiatry, from apathy, anxiety, depression, hallucinations, dementia, all of those things. But unless we ask about them specifically as clinicians, we don't necessarily hear about them. I can't tell by looking at that man that he's badly constipated, or that he's having difficulty passing his urine, or he's not sleeping well. But all of those things are impacting upon his quality of life more than his tremor is. So non-motor symptoms are very common, and they can often predate the motor symptoms and actually be prior to the diagnosis. And quite often, patients have more than one. And it's not a competition, but people can have 10, 11, 12 of these, and we need to address them all to make sure that quality of life is maintained. And sometimes patients will present to their GP or somebody else with a complaint which is actually a Parkinson's problem. But they present as a primary complaint, and then they get treated for that, and they develop a side effect and get treated for that, and then we end up in a kind of deteriorating cycle. So that's why we need to think of everything as being, is this due to Parkinson's, and can we make it better? And the important thing about non-motor symptoms are that they can lead to a reduction in quality of life, regardless of what the motor symptoms are like. And also, they can affect the carer, the spouse, the loved one as well. If a patient's having difficulty with memory or having difficulty with continence or those kinds of things, that can affect the carer, not just the patient. So this is a really busy slide, and the only reason I'm giving it is basically just to show you the wide variety of symptoms. Postural hypotension, anxiety, apathy, depression, skin problems, sleep. Now, you're not necessarily going to get all of these symptoms, but they might be part of your Parkinson's. And if so, we need to address them. And I think it's really important, and there's that we talk about that. Pain can be a common symptom that people develop, and it can be quite difficult to describe sometimes. So there's lots and lots of symptoms there that we need to incorporate into our assessments to maintain that quality of life and ensure that you're having as positive an experience as possible. Coming to the end of what I'm going to talk about, there's a thing called non-motor offs. Now, you're probably aware of on when you have the least Parkinson's symptoms and off when you have the most Parkinson's symptoms. And you can switch between those two. You can wear off gradually or sometimes suddenly. But what people don't recognize necessarily is that can happen non-motorically as well. So people can develop profound fatigue or a sort of a dullness of thinking or panic or anxiety as their dopamine levels begin to reduce. And unless people realize that, it's, and raise it as a problem, they just think that it's part of, something that can't be solved. But quite often, if we adjust the dopamine or do other things, it's something that can be treated and treated well. So when people talk about Parkinson's as being a movement disorder, it is a movement disorder. It does affect movement, but it's so much more than that. It's a lot of things. It affects your cognition, your emotion. Dopamine is responsible for moving well, thinking well, feeling well. And actually, we got to really, really take that on board. It's not just about movement. And as Emma was saying, it affects the neuropsychiatric disorder system as well. So it happens to be something that has movement problems, but also affects the sort of neuropsychiatric symptoms as well. Premotor Parkinson's is something that I'm just going to mention, which is often, when we look back before diagnosis, people can often have problems with sleep, acting out their dreams, problems with smell, depression, constipation, and that all helps us align our diagnosis. And we know that non-motor symptoms are poorly recognised by clinicians. And these are the things that are overlooked the most: depression, anxiety, fatigue, and sleep disturbance. But there are things that we can do so much about if we know about them. And it's our job to ask, but it's also your job to tell. So I'm going to just talk about the fact that sometimes non-motor symptoms are quite challenging, because often the dopamine medicines that we give can make them worse. But that's where the art of Parkinson's management comes. There's a lot of science, there's a lot of art, getting it right for you. Not just the textbook, but you. And I want everyone to leave the consultations with me and any clinician with optimism. There's normally we can do something about symptoms that you're experiencing. There's nothing too difficult. Normally we can approach things together and get a solution. So we always want people to keep that feeling of optimism in the back of their minds, that together, collaborating, clinician and patient together, we can get some answers and we can improve that quality of life by treating those non-motor symptoms as well as we can. Right, I'm going to stop sharing my slides. There we go.
Thank you so much, Robin. That's been very insightful and given us an overview of sort of the breadth of non-motor symptoms, and it's useful to hear your perspective on actually how very common they are and your tips on how to talk to professionals about it. So please do start popping your questions into the chat. We have the experts ready to answer them, so do ask anything you like. We're here to answer your questions. And whilst we wait for those to start coming through, I have a few myself that we'll start off with. So the first one is, what's your advice for people who get odd symptoms and they're not sure if they are related to their Parkinson's or not? And I'll address that to Robin.
Talk about it. I've been having this problem with my, numbness in my left ankle or whatever, or I've got this funny thing, as my medications wear off, I start to really need the loo or whatever. Talk about it, because if you raise it as something that you're worried about, well, then I'm worried about it too, because it's affecting your quality of life. And really what we need to do is to start thinking about, well, could this be because of dopamine? Is this a non-motor symptom that we need to be addressing? Is this something that if we change these medications, we're about to? But if we collaborate together and you say, look, I'm really worried about this, if it clearly isn't something that's related to Parkinson's, then we'll tell you. But quite often, the Parkinson's syndrome is quite a complex and wide one. And oftentimes these symptoms can be part of that.
Thanks, Robin. And just to challenge you a bit, what if you've just had you're lucky and you get annual appointments, which not everyone even does. You've just had your appointment with your specialist and it comes on sort of a few weeks later and you don't have another appointment for another 10 months.
So it is really challenging, isn't it? Access is a problem. We do have a marvelous network of Parkinson's nurse specialists that can advise in between your appointments. Potentially, there are advice lines and different things. The Parkinson's UK website, I often direct my patients to, because there's a wealth of information there which can sort of signpost you to other the ports of call, if you like, and you can maybe find out whether the symptoms do look like they're part of the syndrome of Parkinson's. What I wouldn't do is use Dr. Google, because oftentimes you can go down rabbit holes, and sometimes you need a little bit of help negotiating that. And sometimes, we can get people getting very panicked by reading some things which really aren't particularly scientific, or they're maybe well-meaning, but they're sometimes nonsense as well.
Yeah. Thank you very much. And I would just add to that as well, we do have the Parkinson's UK helpline. So if you are struggling with a particular symptom, you're not sure, we're always here and the advisors there can listen and guide you. So the next question is from Suzanne. and I'll direct this to Emma, I think, in the first instance. Are complex visual and auditory hallucinations recognised as a non-motor symptom of untreated Parkinson's?
So we do recognise it as a non-motor symptom, most certainly, and it's something that we encourage you to discuss, and it's something as clinicians that we should be asking about. Visual hallucinations are probably the most common. There's different types of hallucinations out there, and sometimes as well they start very innocuous. It may be looking out the window and misinterpreting a tree as a person standing there. But we recognize that they can be incredibly frustrating, but sometimes they can quite benign. So it may be that, and there's lots of different reasons why hallucinations happen. If they happen very suddenly, certainly my first question would be about, is anything going on for you? So we look at acute deterioration of symptoms caused by, say, constipation. I think most of the people that I work with feel that I am obsessed with their bowel actions, because we know that constipation can really throw things up the pokey. Underlying infections, again, can cause hallucinations in someone that has not experienced them before. So we would be looking at ruling out those sorts of reversible things first. Hallucinations can sometimes go hand in hand with cognitive problems, so we may be looking at that, but they can also be side effects of the Parkinson's medications. But even if you're really very depressed, people can experience hallucinations there, or they may have taken a medication unrelated to their Parkinson's and getting some weird side effects from that. So yeah, it's most certainly something that I deal with on a daily basis when I'm doing my assessments with my patients, and it's something to be really aware of as a person with Parkinson's themselves.
Can I just clarify, because I think Suzanne said untreated Parkinson's.
Yes, she did. Yeah.
So what I would say is that I agree with everything that Emma has said in terms of that assessment, and other medications can be challenging. If, however, a patient is untreated, one might suggest that have we got the diagnosis right?
Yeah.
Because hallucinations early on in the journey of Parkinson's is a bit unusual.
Yeah.
It's not completely out of the realms of possibility in certain situations, but one would suggest that there might be something else at play. Things like the Lewy body disorders that Claire referenced before with Kenny, and there are other things that should be looked into before making a presumption about Parkinson's being the underlying cause.
Yeah, most certainly.
Thank you. That's very helpful. So the next question I'm going to direct to Robin. Are the treatments for non-motor symptoms always reliant on medication? And that's from Paul.
A good question. No, is the quick answer. Often we'd like to try to minimize the medication burden that we put patients under, because obviously it becomes increasingly complex to take. There are some symptoms that, let's take blood pressure drops. So when you stand up, your blood pressure drops. Now, first of all, we don't immediately reach for the prescription pad. What we'd normally do is say, right, are you drinking enough? And then we'd say, well, let's try to redouble our efforts in terms of drink some more. Let's think about salt. Let's think about caffeine and increasing that in the diet. Let's put some compression socks or stockings on and see whether we can get your blood pressure up. Let's modify the medications that you're on. Are you on blood pressure medications you don't need to be on anymore? Are you on things called anticholinergic medications that you might not need to be on? Do we need to fractionate your Parkinson's medications a bit? And then if you've still got a blood pressure drop, then we say, okay, still got that. Well, let's think about the medication strategies that we might be able to put in place. Quite often, with constipation, it might be a dietary change. It might be increasing hydration before we reach for the laxative. So really, medications, bearing in mind that every medication has a potential side effect, it's always worthwhile going through the non-pharmacological methods first and then reaching for medications. Quite often, there are symptoms that you just need to get on and treat, but that's sort of down to the clinician to try to explain and collaborate with you effectively.
May I jump in? Monitoring of your symptoms are really helpful for us as well to get a bigger picture. So this morning we heard about the On app, which was a fantastic way of tracking non-motor symptoms, and they're really, really helpful to kind of bring to us to say, well, I've been sort of looking at this now for the last few weeks, and I notice that it happens when this happens. So that's another really useful way of monitor of giving out the information to us, so that we can have a look to see whether this could be managed non-medically, medically, through exercise, whatever.
Thank you. So the next question is I'm going to direct towards Claire. Well, it's a question for Claire. How do you balance helping your husband relay his troubling symptoms in a clinic appointment against letting him lead the appointment and tell his story?
Thank you for that question. That is such a difficult question, and not least because Kenny has quite significant communication problems. So he's losing his ability to use language and words, to get words out, to articulate what he wants to say. So it is really difficult because in an appointment, whether it's with his GP or with the Parkinson's nurse or the neurologist or somebody else, he needs to have agency and feel like it's his appointment. But at the same time, it's very frustrating if we come away from an appointment not having explained everything that's going on. I don't have a good answer for that. I think it's really difficult. You have to be sensitive to it. You have to be absolutely clear that you're not taking over and falling into the sort of does he take sugar syndrome and talking, in this case, sort of over Kenny's head or as if he isn't there. So I suppose I try and include Kenny. So typically in an appointment, I would say things like, Kenny, is it all right if I tell the doctor? Or Kenny, would you like me to say a bit more about this? Or, as well as Kenny, why don't you tell the doctor about this? And it's very tricky in appointments. I mean, Robin and Emma will appreciate this when there's time-limited appointments. And with Kenny's former neurologist, he was always keen to tell us we had 15 minutes as we were walking through the door. If somebody's taking much, much longer to be able to frame in their mind and then get the words out what it is they want to say, and then it doesn't necessarily always make sense, that's really, really difficult. So I persevere. I try to have sort of self-awareness about it. On occasion, Kenny says to me, Claire, stop patronising me, and I know I've not done the best job I could. But we've been together for a long time, and as often as not, he turns to me and says, Claire, will you tell them? But it is a real balancing act, and I think it's something I appreciate for any care partner with a loved one in these sorts of situations. It's a difficult thing. It just needs work, that.
Thanks, Claire. That's very helpful. Okay, next one I'm going to direct to Emma. One of the most overlooked symptoms is depression. And have you got any tips on how to tackle this one? That's from Susan.
Okay. So yeah, absolutely. I think it's 50%. Last time I looked, it kind of fluctuates a little bit, but I think the MDS had said 50% of people with Parkinson's may develop depression. So I think, and Robin has spoken about this, is to kind of, if you are struggling mentally, is to discuss it, is to talk about it, and often it is with the people around you first of all. But it's very stigmatized, depression still. So depression is often sort of creeps up on us quite innocuously as well. Often I find with depression, your sleep is the first thing to go, and we know that sleep gets affected in Parkinson's anyway. Apathy runs very much alongside, and to be honest, I think anxiety runs alongside depression as well. So it's about, and I mentioned it earlier, self-isolation and loneliness, I think can be killers, to be honest. So it's about discussing it openly in your consultations, contacting your Parkinson's nurse if you're struggling mentally and you feel that your mood is really low. I think it's to tackle it as early as possible. There are different treatments out there. I think it's to give you hope that depression can be managed. There are, again, as Robin was saying, as a clinician, we'll look at medical options and non-medical options, and we will always go with those non-medical options first. And that may be formalized therapy. And there's some fantastic therapies out there. And this, as I mentioned before, there's some amazing research that Parkinson's UK and other universities are looking at what therapy, psychological therapy, is best for people with Parkinson's. But it's also about having plans, safety plans as well, was something that I'm very passionate about when you are finding yourself very low. What can you do there and then? What can you do at 3 o'clock in the morning? And that might be something that you put together with your Parkinson's nurse or with your GP or your loved ones. So there's things. It's to give you hope that this is a manageable symptom, but we need to know about it first of all, and you need to be aware that this can happen.
Thanks, Emma. So changing on to a slightly different topic, and this one's for Robin, I think. Siluria, so excessive drooling, is a little researched symptom. Anna says she's shared her story or their story on a podcast. What is the latest information on addressing a quality of life issue?
So, yeah, salivary drooling is a very challenging symptom for some, and people describe it as siluria, but just to be a bit of a pedant, it's not actually. You're not making more; you're just swallowing less. So it comes out the path of least resistance. We all make 1.5 liters of saliva a day, which is an incredible amount, and we swallow it. But when you have Parkinson's, that swallowing can become less involuntary. And so you need to remind yourself to swallow. And there's great things like vibrating brooches and badges that can help to initiate swallowing. So going with the non-drug options first. Always see a speech and language therapist if you can, because they'll look at lip seal, they'll look at position, they'll look at all of those things to try to help. If we need to have some options to try to reduce it, there are various things that we know. We know that high sugar foods increase drooling, so trying to modify diet. We know that sometimes sucking sweets, sugar-free sweets, or that kind of thing can reduce drooling by increasing swallowing frequency. And then we think about drugs. Well, the drugs for salivary drooling are challenging, and they're challenging because their side effect burden can cause people to have cognitive side effects. So the best one that we know is something called glycopyrronium, and its trade name's Asico, and we give that to try to dry up the saliva. But you need saliva, so we don't want to dry it up too much. The best thing that I refer my patients for is salivary Botox, where we put Botox into the salivary gland, a very simple procedure done under ultrasound. And what that does, we don't paralyze all the salivary glands, because again, you need saliva, but that reduces the amount of saliva that's being produced, and therefore reduces the drooling. It's not without, you need to have it done every 3 to 4 months if you go down that route. But yes, drooling can be a big challenge. As you say, the research isn't as detailed as it might be. But I think I would normally advise salivary Botox because it doesn't have too many side effects. And then if we need to use medications, glycopyrronium is probably the safer. And all of those issues helped by a speech and language therapist is probably where I would suggest focusing.
Thanks, Robin. So now we're moving on to the subject of sleep. There's an exasperated Corinne who says her consultant, when asked about sleep disturbance, said it had nothing to do with Parkinson's and said she hadn't heard of it in her Parkinson's patients. It's very surprising. I can see, you might not be able to see, I can see Robin's eyebrows and Emma's eyebrows, and Robin has just done this. So I'm sorry to hear that. Corinne, maybe you could direct your consultant to the Parkinson's UK website to do some education on sleep and Parkinson's. But Jackie has asked, any tips for improving sleep? Would melatonin help? I feel so much better when I'm rested. So Robin, let's go to you for that one.
So I agree, you spend a third of your life asleep, and if you sleep poorly, your resilience the next day is lower. And if you chronically do that, then it's not great for cognition or anything, and symptoms and motor function and all that. So again, sticking with the principles of not going to the medication first, I will come back to melatonin. There are many reasons why people don't sleep well. Sometimes it can be anxiety, sometimes it can be stiffness, rigidity, not enough dopamine going in at night. So we need to work out why you're not sleeping, because there are many, many reasons why. And it might be because you're not getting enough dopamine overnight. So a controlled release medication at night might help with that restlessness. Is it restless legs that's keeping you awake? Is it just pure insomnia? Is your sleep-wake cycle reversing? Are you needing to get up to pee? All of those things. So we need to work out specifically why. And then we can look at things like, initially, sleep hygiene. So what's your routine? Are you having the same routine? Are you minimizing the amount of blue light you have before you go to bed? So, minimizing your iPad use or your television use, and actually getting your brain to switch off, which we're quite bad at doing in sort of normal busy lives. Is there a routine? Do you have a warm bath, a glass of warm milk, all those kinds of things that might slow your body down and allow you to? Are you eating too late? All of those things. If we find that there's a challenging, you mentioned melatonin. Melatonin is a great drug for initiating sleep for some people. But we need to, as I say, we need to understand why it is you're not sleeping. We might need to deal with your bladder issue. We might need to deal with your dopamine issue. Melatonin is a good drug, but often we don't get the doses high enough. There are many reasons for parasomnias, as they're called in Parkinson's. There's a whole day's worth of lectures that we could put you through in terms of sleep, but it's fundamentally part of the Parkinson's syndrome. And there's normally something that we can do to improve sleep. We just need to get a proper understanding and work out whether could it be medication induced? Is this another issue? So it's about sleep history, looking at sleep hygiene, looking at simple measures to try and improve things, and then medications can come in. It's a bit of a complex answer. Sorry, that was a bit of a gabble.
No, that's very helpful. Thank you for shedding some light on that. And yeah, such an important thing to feel rested. So thank you. So next question is about Lewy body dementia. In Lewy body dementia and Parkinson's with hallucinations, who would deal with it? Mental health professionals or health professionals? I'm going to go to Claire first to ask who she finds most helpful, and then, or she and Kenny, and then I'll go to Emma. So Claire first.
Yes, I can't give a definitive answer on this, so I think Robin needs to advise on this. I can tell you what our experience. I suppose I'm smiling because it was interesting. So Kenny's Parkinson's diagnosis was through neurology, and through sort of a generalist neurologist, really, not a neurologist who would sort of brand themselves as a Parkinson's specialist. And that diagnosis never completely made sense. So after the neurologist and the Parkinson's nurse repeatedly really saying, oh, it's just Parkinson's-related anxiety, the Parkinson's nurse eventually said, well, if you're really worried, go back to your GP. So we went back to the GP, and the GP referred my husband to what is delightfully called old age psychiatry. So the memory clinic in Edinburgh in the mental health hospital. So neurology is in one part of the health system in NHS Lothian, and mental health and dementia. The dementia is put in with mental health, interestingly, is in a different part. So I think I alluded in my sort of presentation to us straddling different bits of the system, but it was through old age psychiatry that the diagnosis of dementia with Lewy bodies came. And then through that part of the health system, Kenny was allocated a wonderful community psychiatric nurse as part of post-diagnostic support, who you're meant to get for 6 months to get you settled on any medication and so on, but in fact stayed with us for nearly 18 months, which was wonderful. But you don't see the old age psychiatrist again. You continue to see your Parkinson's neurologist and the Parkinson's nurse once a year. So it feels a bit odd. It feels as if Parkinson's is dealt with in one part of the system and dementia elsewhere. And in fact, just very briefly, but last year, my husband went through a complete crisis. Overnight, everything went wrong. He was falling apart. And eventually it transpired it was to do with over-the-counter medicine. But we didn't know that at the time. And my husband couldn't remember that he'd even taken this over-the-counter medicine, and I didn't know. So everything was falling apart and we were in a complete state. And what was interesting was when I reached out to the Parkinson's medics and nurses, they said, it will just be the dementia. And I had to really, really push, and eventually pushed through in Scotland NHS 24. So we had an emergency doctor come out to the house who said, get your GP to do screening for blood test screening for dementia. And that got to the bottom of it. There was a cause, there was a root cause, it got sorted, and my husband got back to normal. So we feel as if we're sort of slightly straddling these different stools, although, as I again alluded, I've now, with the help of Parkinson's in the UK, Kenny's moved to a consultant who is a Parkinson's specialist, and beyond that specialises in old age medicine and has a very, very strong commitment in relation to his patients with dementia. So I think this is this thing about trying to find, the bit of the system that's going to work for you. So sorry, that's a personal anecdote. I mean, that will not be the same by any means sort of across the country, but it's, for us, we've had to find our way in the system. Where can we get the most appropriate support?
Thanks so much, Claire. We're coming up to time, but Emma, what's your perspective on that question?
I think I echo what Claire says, really, that the system isn't set up very well for people with Lewy body dementia. So, for example, Cornwall services, Parkinson services, and most of Devon Parkinson services don't accept people onto their caseload, the nurses anyway, with Lewy body dementia. That goes under the mental health services umbrella. However, we know that it can be a differential diagnosis, and what I mean by that is that, and very similar to Claire's story, is that the person may be referred to the Parkinson's nurses with idiopathic Parkinson's, and then we're thinking maybe not, maybe they're getting quite a big reaction there from their levodopa that they're being trialed on. So we would refer back for another diagnosis or a re-look at the diagnosis to the neurologist or the physician. So we would be part of that process. But I think it's a different system. It's a bit of a postcode lottery, I think, in terms of Lewy body dementia services and the care that they receive, unfortunately.
Yeah, thank you, Emma. And it's something we're trying to reduce, that postcode lottery as a team at Parkinson's UK. But right, we're almost at time. But this one, I don't know if this is fair or not. It might be a quick yes/no. Robin, is there a link between peripheral neuropathy and Parkinson's? Yes. Can you do it in a yes/no?
No.
No.
That's a very simple no. Because if I was German, I'd say yein, kind of ja and nein at the same time. Peripheral neuropathy can be seen as a side effect of some of the medications that we use in Parkinson's disease, but it isn't part of the Parkinson's syndrome specifically. People can develop a strange pain phenomena in Parkinson's, which can present a bit like peripheral neuropathy, and sometimes if it waxes and wanes in terms of symptoms, then it may well be part of something that is dopaminergic. Typically, though, peripheral neuropathy is for another reason, and we think about B12 levels and folate and those kinds of things. So it needs sort of another think.
Thank you. There are some questions we haven't had a chance to answer, so I'm really sorry about that, but there's the Parkinson's question time coming up next, so we will feed any of the leftover questions into that in case it might be possible to get them answered there. But just to finish by saying a huge, huge thank you to Claire, Emma and Robin for being our expert speakers. I think we've learned a huge amount, and I hope, thank you to you for joining. I hope if you suffer with any hidden symptoms, you're feeling a bit less alone, perhaps a bit more confident about discussing these symptoms with your healthcare professionals. And you've got some practical tips from Emma, Robin, and also Claire. And of course, for more information, please do look at our website, or if you're struggling or if you're not sure, you can always call the helpline. So with that, I will close the session and thank you again for joining.
Thank you.
Thank you.